Okay, sweet. I'm sure people will trickle in. John, Derek, thanks for doing this. So if you want to give a brief intro, John, you can, or Derek, I'm pretty sure everyone knows you. If you don't want to, we can just roll right into this hip paper.
Yeah, I mean, if you don't know me, it should be surprising. My name is John Hodges. I'm the owner of Nevada Physical Therapy in Reno. Yeah, that's about it. Any questions?
Starting off strong.
I've been with Derek for 48 hours, so we have to pardon the synapse delays. All right. So this paper that I sent over to you, I really liked it because I started digging in. I'm currently writing our hip arthroscopy protocol. And I don't know if some of you are familiar with like the ACL protocols that we've written in the past, but basically what I do is I just do it more in a narrative-based kind of writing where I try to accumulate all the information. The hip is pretty fascinating just because of how often it's being done. You know, the increased utilization of hip arthroscopies for FAI and labor repairs compared to how much post-operative literature there is. There's a pretty big disconnect of return to sport testing, and kind of there's only maybe in the last 5 years there's maybe a half dozen protocols that I've seen that are any good, right? So there just isn't very much out there. I don't think. There, you disagree a little bit, right?
No, I agree with the return to sports stuff entirely.
Yeah. So
I thought 6 was generous.
It was. I think it was generous. I'm just assuming. I've missed some. But so what I enjoyed about it though is because of this paper specifically, when they went in and interviewed the participants that had had hip surgery, the hip arthroscopies in general seem to have a heavier emotional or psychosocial kind of component than many of the other surgeries. And it makes sense, I think, because these people have been dealing with pain for a longer time, right? So you're thinking about, a threat to their identity, right? They want to be active, they want to be an athlete, they want to be, XYZ. If you tear your ACL, you're operating at a certain level, you get hurt, and then it gets fixed. It's usually a much smaller window of people not being able to participate in the things that are important to them. Whereas the folks that get hip arthroscopy, you typically have been dealing with pain for a long time, right? A few months to, in this paper, more than 10 years. So there's, in my experience, there's a heavier kind of psychosocial component with managing post-op hip arthroscopy folks. So when I was going through this literature and I read this paper, and there's a few other ones that are kind of similar, it was really telling to me about how poor PTs and surgeons do at setting expectations for somebody that's going through this process. So I think one of our fundamental jobs is to create or to set accurate expectations so that when people are going through this process, they told me this was going to happen. This is a normal thing. I've already been kind of like warned, but you can see that we're not doing that. Across the board, everybody for some reason thinks 4 months they're returning back to sport. But when you look at the literature and you look at a lot of the return to sport tests, on average, especially in the pros, 7.5 months. So we have a huge gap between what everyone thinks and what's actually happening. So when I saw this paper, it really kind of confirmed a lot of my biases because the expectation setting comes from us. And if we don't know what the end looks like, right? If we don't know when athletes are returning back to sport, if we don't know when those things are happening, how can we set accurate expectations? So now when I have a patient that has had a hip arthroscopy, say, hey, at 4 months, it's totally normal for you to still experience hip symptoms, right? It's normal for you to still have good days and bad days. It's normal for you to still go through this process for several months, from 3 months to 6 months to even 7 months. So that when they are at 4 months, they're not dealing with that kind of heavy burden of unmet, expectations. Does that make sense? So in this paper, this is kind of an interesting one for like a journal club because it's not necessarily like the way the paper is written or the methodology or the participants or the normal things that we would look at. But what it did is it really showed what patients are going through, right? And so when you went back and you looked at some of the literature out there and when you've talked about this in the Barbell Medicine talks, and a lot of our patients' beliefs about their bodies come from their healthcare providers. So hearing other people say it, I think is always just a good opportunity for us as PTs to get a reminder, right? That this is a very important part of the process, right? That these people are looking for us to give them expectations, or to kind of give them, what the layout's going to look like, the timelines are going to look like, what are normal, symptom experiences and things like that. And so PTs are not very good, and surgeons are not very good at setting that expectation. And this is what we see in this paper over and over, right? They're frustrated, they're depressed, they think that they're supposed to be a certain spot and they're not, which then creates that, anxiety and all those other things that can really just kind of derail, someone's progress, because they could be objectively doing very well, but because of this kind of false expectation setting or inaccurate expectation setting, they don't feel like they're doing well. Right? If someone's at 4 months and they're strong, they're lifting, they're running, but they still have some hip soreness, so they get some hip flexor, irritation, whatever it is. If they don't know that that's a normal part of this process, what's the first thing? Like, oh my God, like I had the surgery, it's not working, like, it failed. My folks, they tend to catastrophize with hip arthroscopies more than I see it with other ones, right? I hope the other hip, I don't have to get the other hip done. Oh, my other hip's starting to hurt. My good hip's starting to hurt. And, so us creating a narrative that is more accurate with what we see. And there were some other articles, and I can send those to you if you want, but there's more articles. If you look at, a lot of the improvement comes in the first 3 months, right? That's where we're going to get the big wealth of changes. But the process is another 3 to 6 months. I mean, it can be, a much longer scale than I think most people are, that most people believe, right? Because that's the whole point of this paper, was that for some reason, 4 months is the running thing. So anyway, I don't know if you want to talk about anything in the specifics of the paper or things that you guys thought were interesting, and we can kind of discuss that. You kind of tell me, Chris.
I'll open it up to anyone who has initial questions, and if not, I have a few.
I'm still going. Yeah.
All right, perfect. So going to the reason, like, why you're writing a protocol, like, is it to give to your patients? Is it to give to other, like, clinicians, or what's the goal with that?
Yeah, so good question. So I think it's more about how my process of learning is to go and I have to take something from the very beginning and to the end. I have to exhaust all that, I can't learn multiple things at once. Like the way I operate is, like, if I'm doing the hip, it's the hip. Like I can't even, we were talking about tendinopathies in the clinic on Wednesday, and I'm like, I want to go dig into that research, but I can't right now, because I just, the way I process is by going through and finding all the literature that's out there, at least, that's of a decent quality, appraising that, starting to kind of pull those pieces apart and seeing how I can kind of maybe create something that's more useful for other PTs, for patients, for from a business owner. This has been a big marketing tool for me. So if I write protocols, or a lot of times I'll have the surgeons kind of consult on some of these things, so like, for example, weight bearing, so they're supposed to be toe touch weight bearing or partial weight bearing for, 3 weeks. That's the general recommendation. And it comes from, because there's a risk of either the labor repair failing or fracture or whatever it is, that if you track that all the way back down, it comes from one guy, a case study that was, I think he was running 10 miles a day or 3 miles a day at 10 days post-op. I mean, like, just a very high load, but it was this one guy, one case study that started this entire trend of not doing weight bearing as tolerated. And so there's 2 papers that came out this year about, we don't see that happen. We don't see these adverse events happening from letting them weight bear as tolerated. So I can have this conversation with the surgeons and say, hey, are you reading something different than what I'm reading? Because here's what I have. And they'll come back and like, typically, it's that, belief change concept where they'll move the needle a little bit more. So currently, as it stands, as long as it's a straightforward hip arthroscopy, it's not dysplastic or any of those things, then I can weight bear them as tolerated. So it's these conversations that is why I go through this, is so I can start trying to update both surgeons. When somebody is going to have a hip arthroscopy, I'm going to be the guy that they think of, because no one's read as much in Reno as I have on this, because I'm putting this information out constantly. So when I write a protocol, I write it in that narrative base because I want patients to also be able to read it, but I also want other PTs or clinicians that are interested in this stuff to see it. I think just looking at a protocol is garbage. You know what I mean? Like, there's nothing helpful in looking at a flow sheet on when we can do exercises. If no one's explaining the whys, then I think that's where we get stuck in our field, that we're not progressing things because nobody actually understands why we're doing the things we're doing, right? This is when knee extensions for ACL. We're finally like, people are like, okay, I think we can do knee extensions for the ACL. Like, because nobody was ever talking about, well, why can't we? And where did that come from? And so this is really what I do, is I just try to create more conversations. And then for me to learn, it's how I have to do it. I have to go through this whole thing. So anyway, long drawn out question.
So to the like or what you mentioned about the surgeons, is there been are they not giving a protocol saying like, okay, you have to do this? Has there been much pushback where you're like, this is what I found, this is what I'm, rolling with NevPT? Has there been any kind of like butting of heads with surgeons?
I typically only work with surgeons that I have a good relationship with.
Mm.
I won't work with any like the assholes or, these guys that are just like very dogmatic or that I can't have a conversation with. I don't work with any of those guys. So I handpick pretty much the people that I want to work with, and they're people that I can communicate with, that I can text, that I can give, we can bounce ideas off of, that are very open. So not really, I don't really get pushback on that group, but it's definitely a biased sample. In general, they want to be a part of this. Surgeons, this is the other thing I think physical therapists forget about. Surgeons don't know fuck all about what happens after they leave the OR, right? Like, they don't know what PT looks like. They don't even know, they think we're all doing the same thing. The return to sport testing. You can ask these guys, like, what are you doing what's your return to sport criteria? They're not, most of them are not well educated on what happens after, right? They see them a month later, 6 months later, these checkups. So I think it's important that PTs look at themselves as educators to physicians as well, right? So the surgeons that are doing this, they want to be a part of this process. The ones that I work with, I only want to work with people that care, so that having them involved. And then again, marketing, right? They feel a little bit of ownership because they participated in writing this protocol. They trust me because they know that we've gone through this process together. And I'm the one teaching them on what we're doing in a general sense. So it's really depends on how you want to use it. But that's why I write them the way I write them, right? Instead of just here's a flow sheet or, the traditional way that you see most protocols.
Just for some of the younger clinicians, I would build a relationship before you start going too much down the road, other than asking how a physician sees certain things, because you can burn some relationships with saying, here's what the literature says. Are you aware of this? Right? Because now you're putting them into a corner of where they're supposed to have some expertise, and that can get some pushback. But if you say, hey, I've read this, are you aware of this? Where are we? And asking questions of how that's relevant to how they see things, oftentimes you'll have a better response, and then start building that relationship. Just in my years of practice, putting them in a defensive position typically means that they lock down and they shut down in their responses until you've had a relationship with them. You can challenge them once you've built that, but if you're building that relationship early, I'd be very much more along the lines of asking questions rather than teaching them anything.
Yeah, and I agree with you. I think when the way I would phrase this, and this is literally what I'll say, is I'm like, hey, can I share this paper with you on weight bearing? I haven't seen anything, that is for partial weight bearing, or is there something that you guys are reading that I can't find, or can you share with me like why you want to do it this way, and let them kind of explain it. It's the classic kind of like epistemology type stuff, where letting them kind of try to explain it and then realizing we actually don't have this, right? I actually don't have a good explanation for this. Now they are open to maybe feedback, but I agree with you 100%. I always try to ask questions. I have an intent with what I'm trying to do, but I do it in a way that I'm not trying to put them on their heels, right?
Right.
That they're
right. Yeah. In my area, Hal Martin's big, right? And he's big on the hips. And so he's in my area. And so we had a lot of physicians where I was before. I was director for the largest orthopedic group in North Texas, right? So dealt with physicians a lot. And if they were instructed by him, they followed him. And it's kind of, well, but do you know why those things are in place, right? And then you have to get to that, you say the epistemological aspect of, do you really understand this, or are you just following somebody else's teachings? But you have to build that relationship to really be able to challenge. Otherwise, I've seen this paper, have you seen this? What, and those kind of questions. It's much easier to get them to change their own mind if you're asking questions about something and asking their opinions on something, rather than just saying, hey, I think you're off base here. This is where the literature's going.
Yeah, I agree. It's always a conversation of getting them to explain it, right? I mean, like we do this with patients all the time. So, 0 out of 10, how valuable do you think this exercise is for you? 3. Okay, why isn't it a 0? Well, I've noticed that, I am getting strong, and they're now explaining like why it's not a 0. And all of a sudden, they've just talked themselves into why this is a valuable movement, right? So it's a similar idea with the surgeons is, well, why do you do that? I'd say that's a good question. I don't know why we do that, and then now we can have a conversation.
I want to go back to the paper's expectation setting. How do you approach with your physicians that you have these relationships with when they set an expectation of 4 months and then we're having to recalibrate that expectation for 7 months, right?
Mm-hmm.
Well, my physician said this, because I know I've talked to my docs in the past and they're like, yeah, but if I tell them that, they're going to go down the street where they get told 3 months, right? I mean, it's always this kind of bidding war almost of who can do it in the name that tune game, who can do it the fewest bars to get the patient down onto the surgical table. How are you combating that with your physician?
Yeah. So again, I think it kind of goes back to these guys don't really know what happens in that, 6 months after. I mean, they have a general idea, circumduction or whatever it is, So it's an opportunity for me to say, hey, they usually, the 2 main hip surgeons in Reno, one's from Seven Hopkins, the other one's from Stanford. They're both very like progressive guys. They're both very open to these conversations. They're both good at not setting that 4-month expectation. Like we've talked about it. I'm like, hey, I'll just share it with them. Like, you see this paper, NBA was 7.8 months to get back, whatever it is. Like, yeah, it's interesting. So what happens is like, we're kind of having these like conversations just about return to sport testing or whatever it is. And then by default, that bleeds into them not setting expectations. A lot of the surgeons I work with, I get pretty much full reign on everything after surgery, right? So they're like, you can run when John says you can run. You can return to sport when John says you can return to sport. But that came from these conversations where I shared at a conference that, 80% of surgeons' criteria for return to sport after an ACL was how long has it been since surgery and how are you feeling? And 2 of the surgeons came up to me afterwards like, yeah, that's exactly what we do. You're right. I'm like, thank you. And they're like, okay, you do all the return sport testing. Perfect. So it was not attacking them. It was just sharing. This is just a paper. I'm just sharing. This is what people do. And then they could walk themselves like, is that what I do? Yeah, that's what I do too. All right. So in general, I don't get much pushback. I do have conversations with them about more of the psychosocial type things of like, dealing with, heightened, anxiety and depression and all these things before surgery. And that's really important for us. And that's kind of like marketing side, right? Like, hey, I'm really focusing on managing this person from the psychosocial end, right? I got people that have a really painful post-op hip experience. I'm just crushing their shoulders, right? They're doing seated dumbbell, overhead press and curls and lat raises and all these things that aren't even the hip, because these are athletes that can't participate in things and they're sliding down that like depression scale. So I'm like, fine, hip sucks right now, but we're gonna make this super intense. Like you're gonna have a really hard workout, but only 20% of this has anything to do with the hip. And so those are the conversations that I'll then have with the docs, and then I'm, hey, this person's, they're dealing with a lot of, potential depression and anxiety about this. Here's what I want to do with them, whatever it is. So that they understand that I'm not just following a protocol or I'm not just treating a body part, but I'm trying to treat an individual. So when we start having expectation setting conversations, I'm speaking a language that most of the other PTs in town aren't speaking. You know what I mean? No one's having these conversations really. So that's in general the direction I go, if that makes sense.
That's fair. I mean, that paper just came out, like 94% of med schools don't have any kind of set pain program, right? At most, it's a 6-hour course or something like that. So they don't understand that whole psychosocial and pain experience component in general. So if you're speaking that, you're actually speaking outside of their wheelhouse. And while they won't never admit it, they're going to kind of give you a little more leeway on that side. And as long as you're giving them, I mean, my docs things where if they're not coming back and complaining, they're hitting all the milestones, and then you're telling me what's necessary, we're good to go, right? I don't want them coming back in hurting worse, doing these other things. So they had more of a, as long as we're not having the negatives, do what you do, right? And so that was kind of the way to get there, is that same kind of a process, kind of talking about, we're doing other things, like with my ACLs, we're doing upper body, we're doing all this stuff. If they're linemen, we're working on sticky hands, we're keeping them in the game, we're teaching them how to read film and do other things, because that's part of their process of return to play anyhow. And we're going to own part of that component, right? And so the docs are like, well, shit, that's outside of my wheelhouse anyhow. Do what you do, and just, no negative side effects, and we're good. And that was really kind of the realm that we played in.
And I think that's exactly, I mean, Derek and I have had this conversation multiple times in the last couple of weeks. It's really kind of baffling to me about how people want to be in sports medicine, but they don't treat their people as athletes, right? I mean, you come in, I got a guy who's got a patellar tendon research, it's 4 weeks out. He's doing great, but there's only so much we can do for the first 4 weeks. So what's he doing? He's doing floor press. He's doing, overhead press. He's doing single leg RDLs on the non-surgical side. I mean, like we're working this guy pretty hard, but it's not like rocket science. This isn't like a difficult thing, I mean, but it's amazing to me that people that are in sports medicine, that are sports medicine physical therapists, that don't treat them as athletes, right? You're here for your knee, whatever it is, post-surgically. And so that's all we're going to do. We're going to do little clams and little, the stretches and all these things. But what about the other 93% of the individual that's sitting in front of you? And so the recommendation, I mean, I think the original point to your question, the younger guys, what I recommend is finding docs that you can access, right? Guys that, a lot of our docs, I can text them, I can get a beer with him. Like we have good relationships, and it makes the entire quality of care better, right? I can bounce them up. My guy that's the patellar tendon reconstruction, he's doing amazing. So I text the doc, I'm like, he's killing it. He's doing awesome. Like, can we, maybe start bumping this up a little bit? So, but I have to be able to have that conversation first, right? Because there's a bunch of docs in town that they won't respond. I can't get a hold of them. Like, I'm not going to work with them because it's too hard for me to be progressive, for me to do good work if I have no feedback from the other side, right? So, well, I'm going to say my thought. Any other questions?
So I have a question about the paper again. I thought it was really interesting to read that emotional toll that goes into this, and also like the mismatch of expectations. And so for me as a new grad, I just started practicing like a month or two ago. What I'm struggling with is trying to set realistic expectations, but also in my mind, I'm trying to not almost create like a self-fulfilling prophecy of like, oh, you're going to be in pain for this long, and that kind of thing. Am I mixing like surgical versus non-surgical? Is this like, or how do you guys navigate that? And am I even having the right thoughts with this?
I think I understand what you're asking. Is you're trying not to like nocebo somebody, basically, right? Like you're basically like, hey, it's normal for this hip to hurt. Like, oh, it does hurt. Like, can you.
Yeah, exactly.
I typically speak in more of like a third person type context, right? So I do this with like a lot of the mental health stuff too, right? Someone that's going through what you're going through, it's not unusual for an individual to experience, anxiety and depression and really have a hard time with this emotion. Not saying you are, I'm just saying it is a common experience for people to go through that. Those are valid emotions, just, we can have that like little quick, they don't even have to answer, right? It's just me letting them know I'm aware of that there's a lot more going on than just your hip hurts. And then with what you're talking about, setting expectations, the way I typically frame, like, it's not unusual, it's normal, and it's expected if you do experience symptoms anywhere from the 3-month mark to the 5-month mark. It's a normal thing. Doesn't mean you're doing poorly, doesn't mean that things are going sideways. It's just, that's what we see. And so when patients have, they just know, I warn them, but not create this nocebo. That's the art part of, what we do, I think, is just figuring out when it hits and when it doesn't. I mean, we're constantly having these conversations of how to use better language, right? Instead of when patients come in, how are you doing today? Well, if I was good, I want to be here, Instead, it's like, so what have you been thinking about? They come in like, tell me what's on your mind. And then it's a totally different question, right? They're like, well, haven't been able to work or whatever it is. And so it's learning what language seems to resonate better to the individual, right? How do I like, to the earlier point, how do I ask a question without making somebody defensive? But PTs, I think in general, the ones that are thinking about this, when I'm teaching students, this is just people communicate. I mean, a spouse, a significant other, a friend, like being able to have those types of conversations are really important, right? So conflict resolution and intimacy. So intimacy comes from vulnerability, right? Not like intimacy in like a sexual way. Intimacy is that I'm vulnerable. You allowed me to be vulnerable. We had a conversation. Now we are much closer, right? So if I can create vulnerability with myself, or, you know, if a patient demonstrates vulnerability, then that's an opportunity for us to be closer, for that therapeutic alliance, right? So I can connect better. So when I'm setting expectations, I'm always trying to just let them know that I'm thinking about it, but not put them in that spot. Because some people will get really uncomfortable, right? You got depression? Yeah. I mean, like, that's never the conversation that you have. So it's, I mean, I've been doing this for 15 years. It's always a trial. We're constantly just like, I don't feel like I feel like that came off wrong, right? They didn't respond the way I was thinking. What's a better way to maybe I could ask that question? How do I get people to kind of have these conversations in a way that they feel safe? Our clinic is like this gym, basically, right? It's open. We have one private treatment room, which we've never used. And so everyone's out there. So to have these vulnerable conversations in an open setting, there's a tact and a skill to that. And that's why I typically talk in like a third person, but.
God, that's super helpful. Thank you so much.
Mm-hmm. Anybody?
So what are you using for your return to sport criteria?
For the hit?
Mhm.
Well, I haven't gotten that far yet, but where I'm trending towards is a abduction adduction ratio. I'm trending towards a Y balance testing. Testing, obviously, our usual like workload, like one of our actual criteria in our ACL is that they have a 70% workload, you know, before they can get cleared to go full release, right? So that last month or last 6 weeks, they're just building their workload. So it'd be similar to that. I'm looking at hip extension strength. So there's some, as far as post-operative predictors, you know, normalizing hip extension strength, just like with the ACL, you know, normalizing knee extension strength. So hip extension strength, abduction, adduction ratio. We use what we call a functional ratio, right or wrong. It's you know, a side plank hip abduction test and a Copenhagen test. It's not apples to apples, but it allows us to get at least a symmetry test from side to side, right? If you can do 10 Copenhagen planks on one side and 4 on the other, okay, we have some work to do. But comparing their actual side plank hip abduction to a Copenhagen, trying to create a ratio, I think would be a flawed premise. We're doing
Use a manual muscle test, right?
no, we use a handheld dynamometer and a crane scale for most of our testing. So
John, for that, the Copenhagen versus the abduction, why do you do that compared to, like, well, you said you do the dynamometer. Are you doing both? Like, are you also testing abduction on the dynamometer, or using the functional testing?
Yeah, so abduction, adduction, I'm testing with the dynamometer. I call this a functional, you know, test of doing the Copenhagen and the side plank testing. And really, I don't know if this is right or wrong. You know, I think that it allows me to, one, highlight asymmetries, right? If they can do 30 reps on one side and 20 on the other, you know what I mean? So it's really more of just giving me like a snapshot. And we've talked, Derek and I have talked about this a lot, but there are no one test that's valuable, right? ACL return to sport. I mean, they can crush the limb symmetry, you know, isometric, right? That doesn't tell me a whole lot because they still suck at peak power. They still can't jump. They still can't, you know what I mean? Or it can be the opposite, right? Their single leg and their triple hop tests are great, but they have a 30% deficit on their isometric strength. So we use, and you'll see this when you're up here, but we do a peak power test. We have a Kaiser knee extension unit, which is really cool for this. It allows me to track power, and it's a speed-based test, right? So it's how fast and how hard can you do this? It's a poor man's biodex, right? So we'll use like a peak power test because it gives me a better picture than just an isometric. So that's how I visualize this with the hip. Is I want some isometric testing because it's reproducible, it's you know, pretty discrete, and then I also want to see more of a functional movement. How well can you do some of these harder things, right? Copenhagen, I mean, if you just kind of think of how many of your athletes come in that actually can do 10 Copenhagen planks, like I look at return to sport testing as what are the risk factors for groin injuries, right? And then I'm just going to back out of that the other way because there really isn't anything out there. I mean, and this is the problem with the prevalence of doing hip arthroscopies and the minimal amount of information on what we should be testing for them to be okay to go back to sport, right? There's some star excursion, which I don't like because I think it's pretty subjective. So that's kind of the direction we're going. This is weird to talk like this.
Mhm.
Yeah.
You're talking to them, I'm just trolling.
Okay. Oh, you're trolling. Okay, excellent. How was my answer? Do you have a problem with it?
I have a problem with everything you said.
I'm having a great time. I'm having a
What
great time.
about if a patient comes in and they have hip pain and they're asking if you would your thoughts on hip arthroscopy? Has that one happened? And then two, how do those conversations go? Derek's
Yeah.
fine.
It happens weekly in some context, whether it's a rotator cuff and ACL. I actually wrote a blog on ACL, if you do need surgery, right? Just kind of, and so what I do, I try not to give my opinions very much in those types of situations because those are very intensely personal decisions for patients to make, and they need to make that decision themselves. So I just try to share the information. Here's the base rates. Here's how many people have what you have that are asymptomatic, right? Maybe it's 20%, maybe it's 60%, depending on what we're talking about. Here's the outcomes, right? So in the ACL, right, 95%, 91% think surgery is going to get them back to where they're going, right? So there's another mismatch in expectations. They think they're going to get surgery and they're going to go back to what they were before they got hurt, but only 2/3 do, right? So I share that information that there is no guarantee that the surgery will help. I have my biases of why, that our numbers are so shitty, because I think PTs in general are kind of shitty, you know what I mean? So I think I was telling this to Rob Panarello last night, I think we're going to see that stuff improve as more people are focusing on getting better. But I think for 20 years, there hasn't been a lot of focus on getting better in our field, right? People just did what they did and they read the paper and they do the things. But now we're over the last 5 to 10 years, I feel like there's a lot more reflection on how can we do this better? Why are you doing this? With social media, you can't say dumb shit and not expect somebody to call you on it, right? So there's this more of this kind of peer review process happening on a social media level, which has been, I think, really fascinating. So when somebody comes in and do I need hip surgery? I don't know. What do you have going on? Here's what you got going on. Here's what the literature says. Here's what the post-operative outcomes look like. Here's what you can expect if you do get surgery. Here's what you can expect if you don't get surgery. But I'm not telling them you need surgery in general, right? I mean, there's always a couple, but in general, that's what I do. I share information and let them make their own decisions.
I always try and lead with, well, ultimately this decision is up to you.
Mm-hmm.
All I can do is present the evidence and I'll support whatever decision you make.
Yeah, exactly. So and I use a different word. I'm whatever decision you make is the right one. You know what I mean? If you decide to not get surgery, it's the right one. If you decide to get surgery, that's the right decision. Whatever you think is the right decision, it is the right decision. And then I also always tell people there's always a plan. It doesn't matter if you get surgery and it sucks, it fails. Back surgery would be a good example, right? You had back surgery and I still have all these things. And I always have a plan because I'm treating an individual, not a part, right? So getting them back to meaningful activity, teaching them coping strategies, addressing psychosocial contributors to their experience, getting them to understand the things that they can control. So Nick D'Agostino wrote a fantastic blog on our website about the dichotomy of control. Those are the conversations we're having. You want to try to control the thing you can't, but you might be missing the things that you can control, right? And so a lot of these conversations are a little bit higher level, but they're not me recommending anything.
Yeah, that makes sense. Or would you ever not recommend something?
Would I ever not recommend it? I would share that the evidence may not support this decision, right? But I don't because I'm not recommending anything, right? I'm just sharing. So one of my techs, she's a sprinter. She's a UNR sprinter. She had a non-mechanical meniscus tear. Surgeon's like, hey, you'll be back 6 weeks, full sprint participation. She's like, what do you think I should do? I'm like, it's not about what I think. I'm like, but here's what the literature says, right? It says that this is typically not a surgical intervention. It says there is no guarantee that, getting surgery is going to make you any better than you are right now. And I share that information. And then she's like, I'm getting surgery. Because she had a lot of the context of the docs being like, you need to do this. And then they were really pressuring her to get it. But I didn't give a recommendation. I mean, my heart of hearts, I'm like, you don't need surgery. You definitely don't need surgery. It's not mechanical. It's just some joint line pain. This is very manageable. But psychosocial contributors, coach, track, athletic training, right? They're all pushing her to get it. My doc says it's gonna be 6 weeks. It ain't gonna be 6 weeks. I know it's not gonna be 6 weeks to be back full participation. She's 8 weeks out now, and she's just getting back on the track. So the doc is setting these unrealistic expectations, which then now she starts struggling, right? She's 6 weeks out, said it was going to be fine, said it was going to be back running. I'm not, it hurts. So that's why I don't give recommendations. I just generally share information. If somebody pins me, they're like, hey, I want, if this was you, what would you do? Fine. I want to do it. You know what I mean? But they really need to push me to get me to give them like an actual recommendation for or against.
This, I mean, it's probably easy now since you've been having these conversations for so long, but like, what would you recommend to like a new grad or someone a few years out, where like if they're asking for your opinion and you or your recommendation, and you like probably already in the back or in the front of your head, you already know like these are the base rates, these are the like XYZ. Do you like just have a chart of that, or how do you even go about, seamlessly doing that in a conversation?
Yeah, I think I understand your question. So for new grads, I mean, I think it just kind of goes back to the original, my fundamental idea. When you're old, you get this. I think I'm wrong all the time. So if I believe that the things that I think are right now are likely going to be wrong in the future, it tempers my confidence in giving some of these really strong worded opinions. You know what I mean? So as a new grad or as a new clinician, I think operating under the idea that we're just trying to be less wrong and I'm not trying to be right, you know what I mean? It allows you a bigger kind of lane to operate. So that's why I'm not passionate about some of these things as far as it goes, is like, everybody should be doing this, you should be doing this. I don't have those beliefs because I used to think that about a lot of things, and those are all totally wrong. I mean, the way we treat tendinopathy right now, we feel very confident about, and then papers are coming out like, oh, right? We were talking about last night, Nordic hamstring curls. Feel very confident that that's a great movement. Like, well, have you seen this? Shit, there it goes. Now the Nordic hamstring curl is going to go away, But like, if you do that a few times through your career, where you think you're very like right, and then 5 years later you're very wrong, you stop trying to be right. We're just trying to do what's in the best interest of the individual. And in general, what's in the best interest of the individual is giving them as much information as possible, treating them as a person, right? Trying to address is this person a catastrophe? Does this person have low self-efficacy? Is this person, a risk of long-term quality of life deficits based on if they were to go get surgery, right? So my one guy, he's a 70-year-old, but he's an animal. He was like Mr. Nevada for 5 years. He's just a legend, right? Guy's got a 700-pound deadlift at like 50 years old. I mean, like, he's just an awesome guy. Tears his rotator cuff, looks pretty damn good. Well, for him, he was dealing with some neck pain for so long that he had stopped exercising. And the thing that he really valued, he had eliminated because he was dealing with pain. So should I get rotator cuff surgery? The guy's only been back lifting for maybe, 4 months. For him to go and shut that back down for another 3 months or 4 months, and then we don't even know if he's going to come out any better than he is right now, that would be a negative, right? Like, the risk of him just going back to losing all these things that are important to him for a surgery that we don't know is going to be any more helpful than what he's doing right now. Like, those are the kinds of ideas that I have when we're having these conversations. How do you recommend something? I don't, in general, I just share information. So with the new grads, you don't have to be, we're not trying to be right. You're just trying, am I doing what I think is the best? And in general, if we don't have enough information, this was Derek's dry needling debate yesterday. If we don't have enough information to say that this is the thing, we probably should err on the side of conservative treatment, right? Like, we probably shouldn't do it then until we find out that there is a mechanism. So does that make sense?
Yeah, that does make sense.
I'll say for sure, backing John's things up, after 26 years, you're going to see things come in and out. You're going to see the narrative behind things that actually seem to work come in and out. They'll have a new narrative and another thing, another story behind why this is or isn't working that will do it. If it's working for an individual, even though I may not have a solid mechanism for it, it's working for the individual. But I'm always trying to stay within the bounds. I use literature much more as a guardrail than the guidance system, right? And it's kind of putting me within a guardrail system of where I shouldn't be, and then staying with what their needs and wants are. Because I'm always asking what exercise, what things, what interest you, right? Because I'd much rather somebody be active doing things, especially somebody that's not getting what they're supposed to be getting anyhow. What do you need to be doing just activity wise, right? What interests you, and can we get you doing that? Because that's my first barrier. The exercise alone in and of itself for the hip isn't necessarily the exercise that they need. They just need to be fucking moving, right? And so how do I get you to that? And what is the barriers to that? I'd much rather get them just moving than fucking deal with the hip overall. And so you just have to meet them where they are and kind of move them forward. Now, if you're dealing with a high-end athlete, that's a different issue, because now they've got some of these other boxes checked off, and now we're looking much more specifically. But we oftentimes get too locked into this specific world when most of the people that are coming in just fucking need to move. Let's eliminate the barriers to movement and get them moving and doing things. We can get a little more specific with things, but most of the literature doesn't tell us that our specificity fucking matters a whole lot. Let's just get them moving. That's got to be the first threshold. And then once they're moving enough, then we can start worrying about some of these other things. And that's kind of how I approach a lot of this stuff. Is most of these people just aren't even fucking moving.
I agree 100%. I think, Chris, to your point for the new grads, I think if somebody would have told me that we're not here to fix people, right? Like that's not our job. We're not here to fix anybody. And if they told me that there is no special exercises, like there is no like these three things, like we have very few, and I would say the Nordic hamstring curl might be one of them, right? Which is now coming under scrutiny, right? So maybe it won't be. But we only have a couple of exercises that we think are actually like valuable for this specific thing. Everything else is opinion, anecdote, individualized care. Like, what does this person think is valuable, whatever it is. So if, as a new grad, if I really learn how to communicate with somebody in a productive way, like in the conversation that Paul was saying, like not making somebody feel attacked or defensive, whether it's a surgeon or a patient, you know, giving them that kind of conversation space, understanding that there really are no special exercises, and we're not fixing people. We're not mechanics. Like it's not our job to fix people. We're here to consult, to guide, to coach. We're here to give them, you know, information. When you plug in the GPS, you get 3 paths, right? And you decide which one you're going to do, but you still got to drive the car. And that's kind of how I view our job. And if somebody would have told me that 10 years ago, I think it would have taken a lot of pressure off of what I thought was important. I used to get really upset if a couple of weeks had gone by and this person wasn't getting better. Like, I'm like, I just suck. Like, I don't know what I'm doing. Like, I felt like it was all on me. But I think to Paul's point, like, if you just get people moving, get people active, make them feel heard and validate their experience, and then start just grading some exposures back into whatever movement is painful. Like this job, we make this job way harder than it needs to be. Like Derek and I joke around about this. Like I want to start a 2-week residency. It'll take me 2 weeks to teach most physical therapists how to be better than 90% of the PTs out there, because that's all it would be. It would be just learning how to validate an individual, finding out what this person's belief systems are, and are there any unproductive belief systems that I could maybe try to change? Can I get meaningful activity back in? Can I get them moving, right? And then the salt and pepper is like, and we'll do some posterior rotator cuff stuff. I don't know, you know, but like we flip-flop that where we get zoomed in on the minutia, and most PTs, they can't zoom out. Like they don't. I had a guy last week, and this is ironic because he was telling me about the PT he saw. He's like, I think he just liked the way his voice sounded. I was like, well, I don't know if you're gonna like me then, because I don't shut up. But I was able to have that, and I was vulnerable with him. I'm like, hey, I got to be honest with you. I'm a little self-conscious now about like giving you my big spiel, because I don't want you to think that, you know, so me being vulnerable with him, telling him, I want to share all this information, but I heard that you had some experiences where PTs just fucking talk. So it's like, oh no, you heard me, like, you know, we connected really well, but it was that skill of just kind of knowing when to be vulnerable, knowing when to validate somebody, knowing when to shift the conversation. That's what I think the new grads and really, I mean, even experienced PTs, those are the skill sets I think that people lack, right? Because it is just being active. My guy came in at L3 disc herniation. I mean, psychosocial to the max, right? I mean, full depression, anxiety. I mean, he's about to cry every time I see him. We benched, we pushed the heavy sled around. We did curls. I mean, the guy was training 5 days a week, and then he'd stopped because he got hurt, went to 2 other PTs. I was telling Derek this, I'm like, I wish I could show like people, they're like, oh, he's here for an L3 disc herniation. I'm like, yeah, we're doing curls. You know what I mean? Like he's benching. Like we're just doing some things to get him to understand, like, you can work out, you can be active, you can do some of these things. And then over the course, it took me a month before we even got to like back stuff, right? Okay, let's start talking about grading exposure. Let's start talking about, these things. So that's what I think the new grads and the young PTs and PTs in general, but I mean, if you're trying to focus your energy, how do I get better at my job? Those are the areas that I would spend time in.
So it sounds almost like you're saying, get rid of your personal pride. Go to the physicians and say, hey, I want to learn about this. Let's talk together. Go to your patients and say, I'm not fixing you. We're going to do this together.
Mhm.
It's across the board. Get rid of your own personal pride.
I think ego is one of the biggest drivers. And Derek made this point in his dry needling debate yesterday that, we're building the bridge over the canyon that we dug. You know what I mean? Like we're giving these people the bridge out, but we're the ones who dug the hole to begin with for them. And so, yeah, I don't have an ego about what I do. Like if a paper comes out and they say, that's not what you think is wrong. Okay, update. Like I don't care about these things that way, right? I try to do better, but I'm not personally invested emotionally into my current belief systems, right? They get updated, they get changed. I'm wrong. The thing about being wrong is once you're wrong a half dozen times, you start realizing that's part of the process and it becomes less traumatic, So yes, ego for sure.
Well, part of it is the human body is a self-healing entity, right? We're just trying to guide it to the task end that the patient has, right? Whatever that is, and then grade the exposures up to whatever level that we're trying to meet. But the body is going to heal. Now, it may be a stiff knee that doesn't bend or a hip that's not fucking movable, but overall, the body generally heals fairly well. So we're really not doing anything other than dosing some little things in to try to help guide that into a direction that the patient has said that they want to go. Right. So where are we fixing any fucking thing when the body's doing the basic work in and of itself? That's what it was kind of designed to do, so to speak. Right. So all we're trying to do is help them get to a task that they specified in a way that they kind of are interested in doing to get to the end result. That's really all our job is. There's a lot of contextuals around it, but that's the basic idea of what we're trying to do. And I think school makes people think that they're supposed to come out and fix shit and it's just the hip or just the knee. But this is a person who has lost their autonomy. They've lost their belonging to a social group. They've lost a lot of these different contextuals that are important to them because of the pain or the disruption in their life. And that's all they're trying to return to. The more we can figure out what those things are, the easier it is to help that person regain those things and move along that path.
Mm-hmm. Yeah, and that's this paper. I mean, like that's why I like this paper. Is I think it was a good opportunity because anytime you hear a patient's words and quotes, right, that's a different kind of research, right? Like it's very personal. They're sharing things, and you get to kind of hear what the patient's saying versus the other 99% of our studies, which is just data and performance and outcomes and all those things. So here's the individual say what they were dealing with. It was just that's why I liked this paper. I was like, man, I think sometimes we lose track of the person and the experience they're going through. And that's where the skills need to be, right? When we're talking about how to be a better physical therapist, it's not doing silly shit, right? Not making things up, and then learning how to communicate with a human being in a way that is valuable to them. So I just think that we get in our own way more than people are aware of. I mean, it's PTs that are creating more obstacles and being better PTs, you know what I mean, than it is any of the injuries or surgical interventions or any of these things. So
I also think that there's this understanding that comes out of schooling, I think, that the evaluation is done in one single day, right? Rather than this ongoing kind of reassessment nonstop type of a thing, that the education is done in one day. Like even looking at the one of the quotes from the paper, right? If we look at the quote, says he did explain this from day one, but I had a fog in my head and it was so much information to take in. Mm-hmm. We have to marinate people in shit, right? And that's what I call this process is we're marinating them in an ideology and a thought process and this stuff. They're not going to take it all in one day. I had a friend that had cancer and he said, as soon as he heard cancer, everything the doctor said didn't stick. He didn't understand a damn thing because he was just thinking of all his internal shit. I got to get this right. I got this. What if I die? What if I do this? I got kids. I got this, all that stuff. So everything the doctor explained, he didn't hear, right? So a one-time fix is never the solution, really. We have to marinate people and constantly have these dialogues and asking those questions. What are you thinking about today? Kind of where are you? Where's your mindset? What are we focused on? Where are we thinking? What are we doing? What do we do? It's a nonstop process. If you think that it's just one and done, oh, I covered that and we're done, that's not the way patients operate. This is a marination process before they're ready and really kind of take ownership of things.
I think I'm trying to baptize these guys, right? I want to baptize them in my religion. No one's getting baptized when the first time they ever drove by the church. Like, oh, that looks interesting. Yeah, you want to sign up? It's this whole process. And what happens, and you think about the way that people recruit for religion, it's sharing pieces. And then something's like, huh, that made sense. I found that. What else you got? You know what I mean? What else you got? And then you get a few of those and they're like, I'm in, I'm bought in. But I agree. Like, I always say this, I'm like, my evaluation never ends, right? This is not our evaluation. This is our day one, but like the evaluation never ends. And you're right, that school is one of the biggest problems. You're going to learn 80 special tests that tell us nothing, right? And then you're going to get tested on that. That'll be on the bar, you know, oh, it's biceps tendon or, you know. And so the students come out of school hyper focused on testing and minutia and the diagnostics instead of learning how to actually communicate, you know, prognosis, you know, how do I create meaningful activity? And you see this in this paper that all is tied together. Expectation setting. It's not just expectation setting. These are patients that didn't feel heard, that they didn't have a useful, valuable conversation with their healthcare providers. They were maybe told things that nobody ever really elaborated or gave them enough information on. Like it's poor communication. You know, it's expectation setting, but it's poor communication to begin with. And so if I'm good at anything in my job, it's just that it's communicating. I literally joke, I can name 4 bones in the wrist. Shit you not. Don't make me list them because I don't even know if I can name 4. That's not my area. I'm not strong in some of these things. I also don't treat a lot of wrists, for the record. So, but what I'm strong at is patients feeling like I care about them, that we're communicating at a high level, that I'm setting expectations and I'm giving, and that everything that I'm doing is for them. You know what I mean? I'm working for them, and that's the culture I try to create. So, and patients, they love me. Fucking love me. Like, so I like them, I think so. Anyway.
That was great. All right, can we go down how the dry needling talk went, or even how that discussion with Rob Panarello went? Is that a debate or is that like a discussion with Rob?
That was 6 hours of drinking beer at a table with Rob
And learning how differently we all, like, I think that was awesome just from a, like, we all talk about like loading, but we were kind of getting into the nuts and bolts of when we start things. And it was hilarious how different even the 3 of us were. And like, I'm pretty comfortable saying we're certainly in like the 95th percentile, being comfortable putting some weight on some people, but even just like highly variation stuff there, like, but I think some of it too, like you almost have to look at it in a like time frame thing, because Rob definitely came up in the 80s and 90s where you based your tonnage off a percentage, Prilipin's table, and like it's kind of cool. It was almost like, in Rob, I don't know if you would get mad because I'm definitely implying he's old by saying this, but like it was interesting because I've seen a lot of that stuff, but I've never seen it done as much, because like I told Hodges earlier, like he kept talking about like Bulgarian methods and all these Eastern Europeans, and I kept trying to like drive the point home to him. I'm like, yeah, all these athletes were on gear. Like you need PEDs in order to do this. And I mean, it was cool. He was talking about how like he'll start running some of his ACLs on like jerk progressions at 6 weeks. And I was like, well, damn, that's like, I haven't jerked an ACL ever. So,
but he gives the why, right?
Yeah.
If we're not talking about the whys, then these conversations are very valuable. So like, well, why? Because you get this ground reaction force, and you get more in quad impulse. Still don't know what that is, but quad impulse. So, but he's you know, okay, like, why are you doing that? He gives your explanation. Now, I treat a shit ton of ACLs. Derek's treat a shit ton of ACLs. Rob sees a lot of ACLs. Do any of us have probably a statistically significant difference in outcomes? Probably not, right? They're probably pretty close because really at the end of the day, we're just talking about how we like to season the steak, right? But the steak is being cooked the same. We're taking people, we're getting them stronger, we're progressing things. He wants to use, a structured kind of percent-based deal. I think Derek and I both use more of an auto-regulation type template. He does things in 6 weeks. I do it at 10. Like, that's what I'm talking about, is that there's nothing special, right? There's no special exercises, but if people can understand the basics, the principles, get people stronger, progress them, don't do silly shit, but like get them going and make it heavy and hard, especially if you're gonna be in sports medicine. Like I would argue, you're not allowed to be in sports medicine if you only have a 30-pound kettlebell in your clinic. I'm kicking you out.
But so there's another point to this that I'm going to go straight preaching to the choir, because you guys are on this call. Like, the bigger thing out of it that kept coming up as a theme over and over and over again is, if you want to get good, you got to show up. And that wasn't like an athlete conversation. That was a therapist conversation. And like, we had a new grad come and join us, and it was like me, Hodges, Rob, and this guy
Greenberg.
Well, and Eric came late. Eric's older than me.
Yeah.
But
So
like,
am I.
yeah, 6 months. But this kid, like, he was sitting over by himself. I'm like, hey man, come join us. And it was really before we got like firing shots at each other. And like, I mean, he hung out with us until midnight last night. Probably doesn't feel great today, but I'm sure he learned a lot.
He definitely doesn't feel great today.
Yeah.
But it was for him. This kid, he was saying, he's like, my job. I told myself I'm gonna force myself to introduce myself to other PTs. Unfortunately, he started with Derek and I, so that was as far as he got. But I mean, then he's sitting with Rob Panarello and Eric Greenberg, and we're all sitting there for hours discussing these things. And we're talking about nuance in training, right? Not the overarching problem with our industry, but we're just talking about different ways that we like to season the steak. But this kid who's been out for a couple of years, like, I think those are the conversations that are really valuable, right? Like, he gets to see, oh, okay, so wait, you guys are all doing things differently. You all agree on this, but there's no special exercises, right? Like, we could all do things differently and still have good outcomes if our foundation is sound, right? They need to get stronger. It needs to be progressive. We need to make sure they're ready for what we're trying to get them back to. So that was probably the best part of the day. Derek's debate, it wasn't really a debate. I'll share them.
Yeah, I think you would do a better job than I will.
So it was, they ended up doing it as like a 10-minute or 12-minute like intro. So Sue Falsoni talked, then Derek talked, and then they got like a closing, like a 2-minute closing deal. So there was no actual like debate, but it was classic hyper focus, right? Like N=1 type shit. She's like, we don't really know why it works, but that doesn't mean it doesn't work. I'm like, well, if we don't know why it works, let's stop stabbing people with needles. Like, I just think like it's a general thing. We shouldn't insert foreign objects into a human being if we're not very confident of what it's doing. So Derek went through a lot of those ideas. So he ended up going more at like a theory approach, right? Like this type of a conversation. Like, if we don't need to be doing these things, then why are we doing them? You know what I mean? And then they ended up closing. But my favorite part, and that's what I was texting some of our other buddies that they were asking how it was going. I said, Sue doesn't know who Derek is, and Derek's quoting Sue's blog back to her. So that's where we're at right now. She just showed up for this like debate, where she just used her slides from her course. And then Derek came in heavy-handed, but never had the opportunity to really do the magic, right? Unfortunately. But it was really interesting to watch. One, she just conceded everything, which is like, that was super underwhelming, right? She's like, I agree with everything you're saying. So then Derek's like, well, why the fuck are we doing this? Like, what if you agree, why are you doing this? But they didn't structure the debate very well. There wasn't a debate. It was basically, you're gonna give a 10-minute talk, you're gonna give a 10-minute talk, and then they got like a 2-minute thing at the end. So there's no Q&A, there's no, so it was a little disappointing on that end, but always good to see, Derek kind of do his thing and present, and I'm biased, but I think he did great. Definitely won if it was up to me, but
Was there a conversation with Sue afterwards, or was there any more like?
I don't think I'm getting a Christmas card this year. So at the end, she, in the crossfire section, she said something to the effect of like, well, it ultimately comes down to an n=1, which is just bullshit justification. And my response was, when you had, and I looked directly at her and said this, and I think this is what really sent her over the edge. It's like, when you have the reach that you do and people respect you at the level they do, you don't get to be laissez-faire with your opinions. You have to be cognizant of what you're putting out and being public facing. And like
Uncle Ben.
yeah, but it is that, like, I've said this a couple times in the last few days, I almost feel like I can tell how much I'm going to get along with a therapist just by asking how well they sleep. And if the answer is you sleep good, like, yeah, we're probably not on the same page.
Right. It's that showing up, right? It's that idea that like it's a constant battle of
Yeah, I got it. Sorry, man.
nice meeting, buddy.
Yeah.
It's this constant idea of like, if you sleep well, it may be that you're not reflecting enough, right? Like, not that you should be like just insomniac type shit, but it's the general idea is that this job is really hard, but not because of what people think it's hard. It's hard because we're treating human beings. We're trying to do good work. How do we do good work? Is the work that I think I'm doing, is that good work? How am I judging that? Like, those are the thoughts, right? That you're sitting there at night and like, I think I'm doing good work. No, 4 people came in today. They were all flared up. Like, I'm the worst PT on earth. Like, I don't know shit, and then the next day, the guy's had back pain for 3 years. He's seen 4 PTs. You got, he's doing great. I'm incredible. They should write a book about me. So it's this violent vacillation between feeling like an imposter to feeling like I'm doing the Lord's work, right? And that's what I think Derek and I have been talking about. It's just that you can sleep fine. If you guys sleep fine, don't take that as like a personal attack. But it's more like how much, and I asked this to my staff, how often are you reflecting on what you could have done better, on where your weak spots, on what things are you doing well with? And those are the kind of conversations that we're having. So when Sue does these things like n=1 and all these like kind of logical fallacies of, it's very important to me. And if we don't know why it works, it doesn't mean it doesn't work. Like, those types of things are actually the obstacles that I'm talking about in the PT industry, that we can't get forward. We can't move forward if people keep just justifying doing whatever they want because results-based, it works for them. Yeah, it works for them. But what about the mass of the other 100 people that it doesn't work for? So anyway, but
part of my frustration with it, so I opened up by being like, yeah, to prepare for this, I haven't had a debate in 5 years. So I literally took a class on debate. And like, one of the things that always came up as a theme there was like, both sides have to be prepared for it to be good. And I think a lot of what angers me and like gets my blood pressure up is like laziness, like
complacency.
But I mean, like, this was a 12-minute talk. I am willing to bet I spent over 100 hours preparing for it. And I was like, I'm going up against one of like the biggest names in the profession. Like, I'm not walking into this underprepared. And then you kind of see how much it was dialed in. And I think like there is an analogy for the profession out of this as well, because it's like, if we look at every outcome paper we have, like there is not much that we're crushing. Like, we obviously have a lot of work to do to get better at our job. And like, to be able to just like, yeah, I got this figured out. I don't know how it works, but I'm confident enough that it works that I'm going to use it. But like, if we don't know how it works, we also don't know how it like affects either. Right. And some of the studies I was citing were the ones where like, cool, you're going to talk about this like physiology. And like, the problem is there are studies where, Chris from like one of the original journal clubs I think you wrote me into, like where it was like you give people this cream, you dye it blue, you dye it pink, you tell them it's analgesic or hyperalgesic, and you get like you get physiological change. And I think it's like in its most charitable way I could frame it, it's okay, I did the test, retest, and got what I wanted, I'm going to move on. But I would also say like some of the most like damning things for our profession is that like when you got the right outcome and made the wrong decision. And there has to be some reflection like on that being a thing in order to like really move the needle. Because yeah, okay, like the person got like their knee felt better after you dry needled them. Well, okay, now every time their knee hurts, they think the knee's dry needle. Or, you know, like, well, why is this? Well, it increases blood flow. Yeah, moving increases blood flow. Well, it increases CGRP. All right, what's the normal level for CGRP? Better yet, like I almost, if we would have had a Q&A, I probably would have just asked like, what does CGRP stand for?
It's the idea that just because something elicits a change doesn't mean it's a valuable change or a change that we want, or that it's a clinically significant change, right? BFR and all the hormonal profiles after using blood flow restriction. Yes, you increase some of these hormones, but most of them aren't any kind of clinically significant difference, right? Like it's a sub threshold. So when people keep hammering this physiology, and then especially with the Sue debate, which was really like confusing, was all the physiology talk, and then also but we don't really know why it works. Like you said that out loud, right? Like you heard yourself that you're listing all these biochemical things that we don't even know why, or if that's even valuable, or if it's clinically significant. We didn't even get into like we never even got to the premise of dry needling, right? Like what are we doing? Why are we even dry needling to begin with? Like, which is where I thought the debate was going to start. But so these are like common compensations, I think, especially in new grads. But I think, I mean, even guys that have been around, you know, for a decade, they keep wanting to find the cool new shit. I mean, when I came out, it was cold lasers, and then it was the Gore-Tex ACLs, and then now it's the bear technique and the bridge repairs. And like, you just keep seeing all the new fancy shit. And then 5 years later, it's gone, right? Dry needling probably gonna stick around because it's a heavy bias, right? The theatrical, like, you know, put my gloves on, get all my needles. Like, it's just a big jerk off session for the PTs, because it's the PTs that enjoy doing this, not the patient. Right? The patient's like, I need that dry needling. It's the PTs that like going through the whole like rigmarole, like they're you know, it's like John Wick, right? They're opening their case, you know, and they do the thing. And that's where I think, you know, we talked about this a little bit ago, but like the ego that we have in our field is brutal, because it's fine to have pride. And I think people confuse the two. You can have pride. You should have pride. I hope that everybody has pride in what they do. But if you have an ego about what you do, well, now you're in that same category of trying to be right, right? Once you think you're right, you're no longer listening, right? There's no more conversations to be had. So if we operate more of this, like I have pride in what I do, I think I do a good job, I care a lot about what I do, and I'm happy with the quality of work that I do. But I also think that 50% of what I believe to be true is wrong. And my job is now to just help individuals. And that's one of the questions I have in the evaluation. Instead of, how's it going? Tell me what you're in here for, right? Like, oh, your knee hurts. It's more like, hey, thanks for coming in. Like, you know, what can I help you get back to doing that you haven't been able to do? I mean, just very different questions. And those are the kinds of trends that we're trying to establish in our field, is people being more reflective, zooming out more, stop creating, like, why are we still fucking talking about dry needling when we have such bigger fish to fry in our industry, right? But everybody's trying to get the dry needling to be legal in my state and all this stuff. And I'm like, how about just teaching physical therapists how to be able to communicate effectively to a patient? That'd be a great course.
You know how many other articles I could have read during that 100 hours?
Yeah, a lot. So, Chris, it was disappointing to say the least.
I will add, I had 5 clinics, and one of them was a 6,000 square foot, purely built, sports specific type of a thing. We had the Ultra G because we had NFL teams calling into our area asking if we had it, and if they weren't going to send their guys if they didn't have it, if we didn't have it, that were local to the community, right? So we got one of those, but we added dry needling because it was an expectation within the sports quote unquote community, right? Because we have in Texas, we have athletic trainers in the high school dry needling. So if you're not doing it in the clinic and they look at it for it's conspicuous in its absence, why don't you have that if you're a sports medicine clinic? But when we track outcomes, we had no difference in outcomes across the board. We had 3 of the 6 people that were in this 6,000 square foot facility certified, and we had no different outcomes across the board over the year and a half that we tracked them.
I get that pressure to like wanting to do the things because the expectation. And this is what I learned, that I don't want to work with pro athletes. It was primarily because of these types of things, right? Like, I don't want to deal with this shit. People that want to work with like pro or elite athletes, I'm like, are you sure? Have you done it? Because it's not actually what you think it is. So I get a couple pro guys, but it's usually a conversation. I mean, I got an NFL guy right now, and it's an ankle thing. I'm like, I haven't touched him. I'm like, I'm not even starting that because that'll get somebody's used to. So like, we're focusing purely on, strength and all these things. But there is an expectation that's set. I would argue though, that in order for us to progress, right? These are all pipe dreams, right? Same thing with reimbursement, right? We have to bury our flag in the sands and be like, no, we're not doing this, right? Reimbursement. You guys need to pay us more for this. I totally actually side with the insurance companies because I think PTs most of them are just doing worthless shit. I'm like, I wouldn't pay for this either. So, but like, we have these pipe dreams, but I do feel like the more people that are not perpetuating this conversation, the faster it is that we can kind of move on. Like, we're still, I mean, how long did ultrasound? 30 years? Like, it's going to take us another 20 years to completely get ultrasound out of clinics. You know what I mean? Like, so once something gets adopted into practice, it takes 10 times as long to get it out. That's where the problem really comes from. Because I don't really give a shit. I don't care what anybody does in general. I have a problem what you're talking about is that the expectation starts coming in. When people come in, they're like, well, this guy does that. Cool. Why do you think that's helpful? Like, and I can get them into this kind of epistemological conversation, but I don't know. I think the more that we cater to the expectations, the slower we are to progress.
So, yeah, I have a couple thoughts. I fully agree with everything you're saying, but I think it is that like, my most nefarious framing of this, and I will fully concede I'm about to go off the rails. So, like, as a therapist, there's only so many patients you can see in a day. Like, and I think that isn't taught a lot in school. Like, so let's take it as the most charitable. Like, you work an 8-hour day, you can get 32 units, and it's $60 a unit. So that's what, $1,800 in a day or something like that. Mm. And okay, cool. That's your absolute max. Well, at a certain point, you start realizing that's your absolute max, and it becomes frustrating because like you're just not going to make any more money as a result. But as someone who teaches Con Ed courses, if you want to have a fun game, think about the fact that that seat costs $500 and you just put 30 people in it. And so now you're like, ooh, yeah, I got a 1x multiplier on here. And like, but here's what I can tell you as someone whose course is like based around cognitive thinking and things like that, like that doesn't put asses in seats nearly as much as let's go learn the new fun thing. And we were talking about this last night with Rob, it is part of that, like, if I do that, my course doesn't change a ton from year to year. Like, it gets updated, but like, yeah, it's not some new thing you need to come learn. It's something you need to practice. Whereas if I'm like, man, myofascial decompression is the jam. All right, well, that shit the bed. Dry needling is the jam. And before you know it, like, we're always just like whack-a-moling whatever the new thing is. And I think, and once again, fully concede there is a high level of cynicism here. But I think a lot of that is related to that realization with the business side of this. And I always think it's funny, like, I love those threads where they're like, what's your ideal day look like? And they're like, well, I want to see 7 patients one-on-one for an hour, and I want to make 100K a year. Like, that math doesn't work.
Right.
Like, sorry, that clinic's going to go out of business in a month and a half.
Any other interesting experiences last night?
Um,
Are there any other talks that y'all really liked or really
I-
did not like?
I actually think, how do you say Jason's last name?
Tory.
Yeah.
Tory.
So he
Clearly,
gave,
that wasn't very confident.
so
Tory. Jason
yeah,
Tory.
we're gonna run with that. So he did a point counterpoint on strength training for runners, and he was doing the like case against strength training, and I think he did a very good job at it. And that's coming from someone who works for a company with barbell in the title. But I think like it's interesting to watch arguments get holes poked in them, and that really is kind of what we should be doing a lot of times out of it. Now, like I thought he gave a good talk. I would have loved to have, or in fact, I did have a nice little crossfire with him afterwards. But like, I mean, it's a pretty shitty hand to get dealt to have to argue that one.
But
So-
that's what was so great about it was like, we know that Jason doesn't believe this, but he was going to do the devil's advocate thing, and he was going to make an argument against strength training for runners. And he did a very good job with it. And that's, back to the original, young clinician thing is we have a tendency, and we've talked about this a lot, that we silo ourselves, right? We have the same 30 people that we're talking to, and we start believing that this is what the conversations are. And then you get out in these like circles, like, oh no, nobody's doing this. Like we've siloed ourselves so much. So part of my process, I really enjoy reading the counter arguments. Okay, trigger point, dry needling. Let me go read all the things that say it doesn't work. And then what makes more sense to me, or what seems to be more like methodological sound. So it was really fun to watch, because we knew that Jason didn't believe this, but watch him like put this information out there and create a pretty compelling argument. Like, makes you reflect. And I don't think PTs in general do this enough, where they go and actively seek the other side, right? Like, I want to go see what the other conversation is, and then I'm going to actually kind of like dig through all this. And they're like, okay, it doesn't make sense, right? There's some big jumps here. I mean, the trigger point is kind of like the low-hanging fruit, because the premise is the problem, right? So, I mean, all the literature that comes after that is pretty easy, because we haven't even established the premise yet, and then we can move on. But Jason's talk was good. We didn't go to any other talks. Yeah. We only went to one.
I am probably not the person to pattern your conference attendance after, because here's the problem. Like, even as someone who does these talks, like if you structure it, like you're not getting my real opinion on it. You're getting what I think I need to present to be digestible to the audience. And that's an entirely different thing. So if it's a topic that I'm interested in, I am much more likely to go try and find that individual and have a beer with them. And I think that is like, it goes back to, the original thing you were saying about making connections with surgeons. Even it's like, all right, that's awesome that you did this, and you did a excellent PowerPoint, beautiful slides, well done. What do you really think now?
And Chris, I think that's your point. Like, I only went to the debate, and then Jason talks. We went and watched him do his talk, and then that was all we did this entire conference. But we spent 6 hours with Rob Panarello, Eric Greenberg, drinking beers and talking. We covered more ground in that, those 6 hours than the whole weekend, right? He's given his Eric's doing all his research. He's giving his Rob's talking about how he's been training guys, and he's got 30 years of experience and what these things. I mean, that's what's so valuable. And that's why we were joking around with the young kid that introduced themselves to us. It's like, that's what these conferences are really valuable at. Like, the talks are like, they're fine. I mean, it's been after a decade of this, so you're kind of like, all right, I've heard it enough. But when you sit down with the guys, and I get to hear Eric Greenberg, who I literally reference on my protocol in like a balloon, like an extra special reference. Like, oh fuck, I reference you. You know, last time we were at, Trevor Lentz, I'm sitting down with Derek and I'm Trevor. Nice to meet you, Trevor. As we start talking, like, well, what's your last name? Lance, I'm like, shit, I referenced you in my protocol. Like, those are the experiences that are really, really valuable to me. But I think that when a lot of the younger and new grads and students, they're very, which is fine, you should be attending the courses, but they lose sight of this is an opportunity where you can introduce yourself, sit down, have a beer, talk about these studies, and you learn 10 times as much. So that was what was really enjoyable. Because I knew who Rob Penderell was, I just never met him. You know what I mean? Now, we burned her down.
All right, Hodges, how much did Vermeil's hierarchy come into play?
Check that box.
And then how often did he go back to like NFL studies of what like a lineman or somebody else has to squat or be able to bench or all that stuff in the return to play?
He didn't get into that.
He didn't go there as much.
Okay.
Yeah.
I've had multiple conversations with Rob. He's a great guy. I really love him. I love his thought process, but it's almost always based off of Vermeil's hierarchy. And then there's always the task analysis, and he usually defaults to his NFL and what those players have to do. I don't disagree necessarily with it, but that's almost always where the conversation ends up in some way, shape, or form.
We probably spent an hour last night, just the four of us, talking about if you had an NFL cornerback with an 80% limb symmetry index, 32-inch vertical running a 4.4, if we were concerned about the limb symmetry index.
Eric Greenberg, very concerned. Rob,
Not so much. Yeah.
And that's what was so enjoyable. Those were the conversations that were enjoyable, right? I don't know who's right,
Yeah.
But it was just interesting to watch these two guys on different ends, do this whole talk. But
it's also fun because like there's not like personal identity involved. Like, I mean, there were multiple times last night where voices were raised, but like it wasn't like, yeah, let's take it out to the streets. It's like, no, I feel very strongly about this. You feel very strongly about it. We need to figure out where the gradient difference is.
or we just recognize that we're talking about the salt and pepper,
Yeah.
right? Like I like a Himalayan pink salt. You like to use a traditional, rock salt. Like that's what these conversations are. We're debating which kind of salt's best, right? You know what I mean? But I think it's important. We were talking about this last night. I think it's important for people to have the nuance, the 1% conversations to try to get everything moving, right? Because it's going to take so long for everything else to come behind it, that if we all just were like, we just need to talk about loading our athletes more. Well, yeah, that was the end of the conversation though. Like that, you need to load your athletes more. So now what? We have to have the people having those nuancy conversations, because then it sharpens everything behind it.
Do you feel that it does? Because sometimes I think we believe that we move the ceiling up and the floor comes with it, but I'm not sure that we're always handling the floor shit, right? I'm not sure that we're moving the floor up.
So you're on my side.
Right.
Fair enough.
I agree 100%. I think the vast majority of our energy needs to be on the floor, right? But I don't think they're dichotomous. I think you have to still be focusing on the ceiling. You know what I mean? So I think that they're still related, but I agree. If I get to pick one, 80% of my time, energy, passion, the floor.
Right. They're not mutually exclusive.
No.
Right. But I do think that we're missing the floor a hell of a lot more than we're missing this thing. There's a very small percentage that comes across in my clinic that needs that ceiling.
I agree 100%.
Well, I was trying to explain to Rob, because I'm speaking with him at CSM, and it's me, him, Dan Lorenz, and Laura Obstadel. And like the first time we had a meeting, like Dan and Rob were talking about like 505 tests and all that. I was like, you guys don't understand how far out in the ether you are for the, like, probably less than 10% of clinics have 10 meters to where you could do a 505.
Mm-hmm.
And like, this was a lot of the conversation that like Rob and I think probably had our biggest like fundamental disagreements on last night, because like my priority one for an ACL is like, you got to meet physical activity guidelines. Like if you're not doing that, I don't give a shit what else is going on. And like, then we start talking about like where or how I might set rep scheme, a press or whatever exercise we're going to do. And because if you look at it, like the average person going through ACL rehab is not getting anywhere close to that. In fact, we're probably like under 10%. And I think, and this is why I tend to side more on the floor side of it, because it's like, all right, I want to live up here in the tip of the spear, but like, if you're not checking this box, we're not even like using the right weapon at this point.
Right.
Yeah, I'd agree. I mean, I think those that work a lot with professional athletes, they tend to be on that 1% discussion because they're treating the 1% of the population that it actually fucking matters. For most people, whether or not you're running a 4.5 or a 4.4 isn't whether or not you're getting paid or not, right? And so we need to be down here just making sure that you're getting the minimal amount of motion and activity done in a regular day versus worried about whether or not I can increase your 40 by 0.01%.
We had like one of my favorite like hypotheticals is, would you rather have a technically beautiful weak athlete or a strong as an ox shitty technique athlete? And like we probably spent 30 minutes.
And it was a split. It was
Yeah.
a split.
Yeah.
Rob will take the technique, and
Yeah.
we would typically take the strong, right?
Well, stronger is usually more useful and harder to kill. Isn't that the quote? I mean,
Well, his case was, well, once they're technically proficient, I can load them as much as I want. To which I said, no, we're talking about right now. Like, I put your technically beautiful versus my strong and ugly on the field. Who wins?
and Rob held that line because normally he wants a level of strength for before they're on the field anyhow.
Well, he was just arguing that if they have technical proficiency, he can add strength.
At that point, he can add the strength without concern. Okay.
But the weak part of that argument was we're assuming time is equal, right? Who am I going to get to be able to perform faster, right? The strong guy. I can spend 6 months getting somebody that has good technique stronger, but if you're already strong and you just have shitty technique, what's that? I mean, we can build that so much more quickly, right?
And then we get to is technique for protection of certain parts, for certain loading of certain things, or is it for ideal weight movement, but is that necessarily transferable to on-field performance? Then you can get down the whole rabbit hole of what technique even fucking means.
I wish I could show you one of our point guards who in Nevada is in the NBA now. I mean, I don't even play basketball. It's fucking terrible. I mean, he shoots and it looks like he's having there's a spasm in the air. Like, what are we doing here? You want to go coach this up? You want to go change this? Like Hunter Pence, right? Scoliosis, plays for the Giants. They tried to hammer this guy to fix his like technique and his form, and he just fell apart. Like, I think we always forget that athletes are specialized, right? They're very good at compensating. And some of these guys are going to have strategies that are going to be different than we would call beautiful, right?
Freaks are going to do freak shit.
Yeah. I'm a Chargers fan, right? Phil Rivers, his delivery is arguably awful, right? It's a very sidearmy, weird, deal. You want to go tell him to change his tournament? The guy's been playing in the league for 15 years. Like, so I think we get so pigeonholed on technique or whatever you want to call it. And again, we don't zoom out. Are we getting people stronger? Like, are we creating obstacles to movement now? Or are we just trying to be the movement optimists, the Greg Lehman movement optimism? And I think that's where PT and strength diverge a little bit, where they're going to be much more perfectionism, mastery. We're just happy that you're actually doing something, you know what I mean? And then less we can maybe tweak it a little bit, so.
That's why we exist in the continuum.
Right.
I mean, really, we should. Well, there's a level of where we have a certain level of proficiency and we have a level of strength. I'd like to be able to take my people, but I never get to, I shouldn't say never, but I rarely get to take my athletes to the full end, right? I either have insurance limitations or whatever fiduciary issues start to come into that aspect. But if they can get with their strength coach and get with some of that stuff, but they're going to be much more along a different mindset than I might have been, right? But if we can communicate and we have a similar language, then we have a better idea of what we're doing all the way through, right? This is what I was seeing. This is what I was working on versus what you're doing. And ideally, those aren't separate entities. Those are blended entities that we're handing things off at different times for different things. Like in one of our, in that sports clinic, all of our strength and conditioning, we had athletic trainers that were CSCSs that would actually handle that other side. So they came in for their therapy, but then they did another hour with the strength and conditioning coach to get the rest of that stuff moving, right? So we always had that on board, and that was part of the whole process for any return to play athlete that was ACL or anything else. They had to spend time with those twice a week with our strength conditioning, because we thought it needed to be concurrent, and then bridging that gap back into, and I know everybody hates that term, but really bridging and getting back to sports, because oftentimes insurance leaves them to where they're basically in the gym by themselves. And I'm sorry, a 16-year-old or 17-year-old kid doesn't know dick of what he needs to be doing in the gym. No matter what I write, I can't see what he's doing, and whether or not he's doing that at the intensities or anything else that I want him to be doing at.
That was Panarello's point, was that he'd rather give them an external constraint. You're doing this much for this, versus where maybe Derek and I might use more auto regulation of like, I want this at this level, right? So yeah, I mean, but again, nuance, salt and pepper, the small stuff.
I agree. I agree. And the problem is anchoring for me with a lot of the youth. It's hard for me to get them to anchor what an RIR is, right? Okay, that's really where failure is, and that's where that is for this, right? And so anchoring becomes a discussion that I have to have, and then I have to go through a process with them. Now, if I'm with them enough time, I might be able to anchor that, and they can go work independently. But if I can't anchor that, it's a real, it's just fucking throwing darts in the wall as far as I'm concerned.
Totally, I agree.
Well, one of the conversations that came up was like how many PTs are comfortable putting heavy load on people. And it is one of those to where, like, Hodges used the example. It's like if somebody has a 225 squat 8 weeks out of an ACL, like, okay, are you done warming up yet? But to like most PTs, like that's
It's absurd.
I would be comfortable saying less than 4% of PTs who regularly treat ACLs would have someone touch 225 at 8 weeks.
Yeah, I was going to say, what's heavy, right? I mean, and is it relative to me, or is it relative to the client?
Yeah.
Right. I mean, Hodges with his 600 plus whatever deadlift. Okay, I've got to be at a much different level than that 125 that most PTs might put onto a bar, because that's probably all they have if they have that bar.
It's fine. Let him. He's fine. Let him. He's good. Are you talking about me?
No, PT putting 125 on an ACL.
Oh yeah, no.
Yeah,
I think no.
Yeah,
You don't think men do that? That's low level for
80%.
Maybe on Christmas morning, and like my hopes and dreams.
I would say 80% don't even have a barbell.
Yeah.
So you know what I mean?
Okay, that's fair.
We get siloed. We think that everybody should be doing these things because we're doing these things. We realize that the vast majority of sports physical therapists.
Now, Hodges, did I under your deadlift?
Oh, yeah, you overshot. Yeah, 500-pound deadlift, 500-pound squat, 370 bench. But my deadlift is actually my worst lift, so I'm a little embarrassed.
You're under your squat for your DL?
No, I'm 501 on my squat and 507 on my deadlift.
Oh, yeah, but
femur.
Yeah, you gotta move that up, brother.
Yeah, well, I'm gonna start doing steroids, so we'll be fine.
You can run gear, so just so you can.
Yeah, and then I'm gonna start the Panarello program. So
right.
Die big, die young, die in a ball.
Only get one spin.
Yep.
No guarantees anyway. Sorry, I know we knew this was gonna go this way. Gonna be very sidebar-y, very tangential. But does anyone have any questions about hip arthroscopies, about that paper, about anything hip related in general? I mean, I just want to make sure that we did due diligence on that.
How are you handling the person that goes back for the second hip? Right, because my issue is really some of these hips come to me on the second round. Right. And which means that they've not only had the X many years of dealing with it ahead of time, that they've had the failed surgery. Right. So they went through and quote unquote failed in the rehabilitation and in their return to sport. And so now they're coming back with multiple years of sensitivity in those tissues, as well as a belief that they're fucked. So how are you handling this?
Yeah, I think distraction is probably my biggest game in the beginning with those guys, because they are so intensely emotional. I have a gal right now who had 2 hip arthroscopies for labral repair. She tore through her capsule repair twice. The surgeon was like, that's weird, never seen that before, I'm referring out. She went to Stanford. They did a femoral derotational osteotomy, So she currently still has a labral tear and a capsule tear. And then she had a femoral derotational osteotomy. For the young guys, I don't know if you guys know what that is, but they cut the femur, they twist it, and then they pin it back together so that the angles are, more ideal. And I have another patient that's a acetabular derotational osteotomy. So they took the acetabulum, rotated it, pinned it back together. But that's her first surgery, right? So the acetabular derotational osteotomy, that's her first surgery. My other guy, that's her third surgery. I mean, night and day, right? Like the intensity. I mean, this gal's still on crutches at week 7. She's dealing with cramping. She's crying. They're evacuating Lake Tahoe, and she's up there, and her husband's traveling. Like very intense, like psychosocial stuff, right? So I handle it. I don't know if I handle it well, to be honest. I mean, like I tell her, I'm like, dude, we're gonna right now the first 8 weeks, we want to maximize the protection for that surgical repair, right? We don't want to overstress the fixation on that bone. But once we get the green light, then there's a different conversation. And this is where that like therapeutic alliance or this understanding the individual, like she's an active, she's a skier. Like, well, here's the plan. The plan is to start kind of grading, like to kind of, work within some symptoms, but her symptom experience is relatively intense. But because I have a good relationship with her, I understand her and I know her. So I'm like, let's give it a couple weeks. And then it might be a little bit of a no pain, no gain situation because we have nothing left, right? We're doing all the light shit and it's just not helping. So the body is so hyper protective, I think, with her, right? It's her third surgery and all those things. So anytime someone's had a revision, right, you can just go ahead and double whatever the, rate of return is going to be after that, right? Second ACL, second hip scope, what?
Hips back.
Oh, so I thought you were judging me.
Always.
Over the baby. So I think what I do is I really tune up on distraction in the beginning, right? Let's do some shit that's hard and heavy, but not hip dominant. And then let's have a little bit more intense or intentional conversations about what do we want to do. And I let them decide, right? So I'd say, hey, here's what we can do. We can start kind of playing around with this. Like, let's just, we do some, for her, she has a really intense quad cramp at the fixation site. So it sounds to me like kind of like hypersensitivity protective type face stuff. So we can do some like gateway, we start doing some walking, some like light leg press, or I let them pick. So I'm like, or do you want to do some RDLs and whatever, right? So giving them a little bit of ownership, they decide. It does two things. It lets them have a collaborative, input to the program. And later, if for some reason they have like an advert, they're sore, they're flared up, everything is symptomatic, it's also tempered, right? Like you're the one who picked that you want to do RDLs, and so then they're much more like reasonable as far as their emotional response after symptom exacerbation if we have any. So, but I think honestly, like revision hip arthroscopies are probably one of my least favorite patients to treat. They're hard. And I think it's because of like this paper, I think there's a lot of psychosocial stuff going on with those folks. So that's probably one of my least favorite.
Yeah, I got
surgeries.
one right now. She had their first surgery, then a derotation, and then she had a second surgery. So she's on her third hip. And it's just, it's a cluster as far as trying to move her forward, because where her mind is, not so much where her body is, but, she can do 135 pound clean to a box, right? But this is used to be at the open competitive CrossFit athlete. And so to her, she's way fucking behind. And I'm like, no, you're doing all right. We just got to keep moving along this process. But she just, where her expectations are, and balancing that is a real tough road.
It is tough. But I think it always comes back to us. Like, did we set appropriate expectations? Did I create a message that was valuable and meaningful to this individual, right? They're not buying in. That's a failure on me, right? Like, I am not like figuring out what this person thinks is valuable. I am not addressing the appropriate, belief system here. Like, I'm not getting buy-in, and that I think is a failure on me. So if people, they don't do their exercises, I don't get mad at them. Like, I didn't create value. Like there is no collaboration here, right? They don't think that this is important to them. I'm failing on that part. And right, this is like a general, right? There's
No, I mean, 100%. I just don't know where cleaning to a box is a failure for her. right? Because she wants to be able to just clean to full depth. But what's meaningful to her is full participation in CrossFit, and we ain't there yet, right?
Mhm.
And so trying to keep her as CrossFitty as we can, but still do that. I mean, we're working her ass off with a lot of EMOMs and stuff, just trying to get her as far as, just work capacity component, what's familiar with her, a good sweat, and she feels like, shit, dog shit afterwards. That's a reward for her, but she still wants to have that full depth of squats and cleans and everything else so that she can go back to full participation. And it may be my personal bias, and maybe she's reading in like, I don't know if we'll ever fucking get there. And so maybe she's reading into that, and I need to actually believe that we can, but I'm not 100% sure we can. And so it may be that issue.
We do. I mean, look at the Ryman paper from 2018, you know what I mean? Like, and that's all just a single, intervention. We're looking at somewhere around 55 to 75% return to prior level of function. You read all the other papers and it's like 87 to 93% return to sport. This is incredible. The surgery is amazing. And then you're like, and I think Mike did a good job with this. Of like, well, but did they go back to what they were doing before? No, they didn't do that. And then all of a sudden we're like, well, maybe this surgery isn't actually as like great. I mean, it's fine. It's like ACLs, but so it's expectation. She may very well not go back to doing what she was doing, and that sucks, but that's just the data, right? Like, I mean,
yeah, Mike and I have had discussions on this because he does a lot of revisions, and I've tried to pick his brain a little bit about that. And he's like, who knows if she will be able to go back and compete at that level? Probably not.
I do think a lot of those psychosocial for sure. I mean, not for sure. My biases are that the psychosocial contributors are just magnified. Anytime someone's had a revision, and especially in these cases, kind of like this paper that I shared, they've been dealing with this thing for a long time. And so their identity has been threatened for a long time. You get a surgery, now you have hope and optimism that this is going to fix that thing. That did not happen. Okay, now it's even worse. It's like, holy shit, like I just already went through this process. So these things start magnifying and building, where I think with revisions, a lot of it, more so than just the general like primary intervention, it's the intense emotional experience that this person is going through, because holy shit, how long do I have to be dealing with this? Like, it's been 18 months now. I've had 2 surgeries. Like, I'm still not back. And that's where I think a lot of us don't like track, you know what I mean? Because I think you like me, at least, what do I need to be doing differently? What exercise? Like, how do I get this person stronger? And I just need to get them to load my gal. I need to get her to like weight bear on this thing. Like, I need to get, I'm zooming in significantly on her, where reality is like, I probably need to like check back in, like zoom out. Like, how are we doing? How are you doing? Like, everything okay? You want to talk? Like, it's like, this sucks. This fucking sucks. She's crying. I'm like, cool. Vulnerable, right? Increasing intimacy. We're connecting. Like, we are closer now, and I can have more opportunity to build. So, anyway. All right.
Boom. I think that's a great place to stop. Unless anyone has any other questions.
I don't.
Perfect. Well, thanks, John and Derek, for being able to get on. I'm sure y'all just want to like have your little bro time before Hodges leaves.
I don't know. We've been drinking this entire time, so it's fine.
Yeah, no one else saw it, but when they both got on the call, they like immediately took a swig like at the exact same time. I was like, y'all have synced up perfectly. Wearing flannel.
We're
I mean,
soulmates.
yeah,
We're soulmates.
at this point, we've just conceded this is a thing.
I love that.
Yeah.
Well, I appreciate it, and this was great. Yeah, y'all enjoy the rest of your weekend, and thanks everyone for joining the party.
All right. Yeah. If anyone ever needs anything, questions, holler at me. So always around.
Oh yeah. All right. Bye everyone.